Acknowledge that the space we occupy today is on the unceded traditional territory of the Algonquin and Anishinaabe people who have lived and continue to live on this land. I would also like to recognize and honor the valuable contributions of the First Nations, Inuit, and Métis people who call this land their home. When we acknowledge the land, we remember unceded means that First Nations people never ceded or legally signed away their lands to the Crown or to Canada. When we speak of traditional territory, we speak of land they or their ancestors traditionally occupied and used. This land sustained them, and as stewards, they cared for the land and the waters that flowed through them for generations before their lives were irrevocably changed through colonization and forced assimilation through the residential school system. In the spirit of true reconciliation, and as the chair of this board, I commit to ensuring the organization moves forward in a meaningful way on OPH's Reconciliation Plan and ensuring that reducing health inequity and systemic discrimination is at the core of everything that we do. And I ask you, my colleagues, to reflect on your continued action to support Indigenous health equity and self-determination of all Indigenous people. Today we have a special opening to our meeting in recognition of National Indigenous History Month and National Indigenous Peoples Day. We will have First Nations, Inuit, and Métis elders offer opening prayers. So I will just, if you give me a moment, I'm going to move over to the podium. On? No. Is this working? It's on? Okay, perfect. It is my pleasure to invite our special guests to offer opening prayers. Please welcome First Nations Elder Irene Compton, Métis Elder Senator Pam Berge, and Inuk Elder Maria Brazo. Please come up to the podium. Thank you, everyone. We will proceed with the agenda. So can we have the roll call, please, Board Secretary?
Member Bannum, Member Bauer,
Present.
Member Brown-Shreves,
Present.
Member Carr,
Present.
Member Chung,
Present.
Vice Chair Di Giovanni,
Present.
Member Dudas, Member Gower,
Here.
Member Kavanaugh,
Here.
Member King,
Here.
and Chair Kitts.
Here.
You have quorum, Madam Chair.
Thank you. We have regrets from Member Bannum, and I know Member Dudas will be joining us a little bit later. Declarations of interest, are there any? Seeing none. Confirmation of minutes of the meeting of April 17th, 2023. Are those confirmed?
Confirmed.
Thank you. Communications, we've received 8 communications items that have been held on file with the Board of Health Secretary. Motion to introduce reports. Member Carr, please.
Be it resolved that the Chair of the Board of Health Verbal Report, the Medical Officer of Health Verbal Report, and the reports titled State of Ottawa's Health 2023, an update, Ottawa Public Health Strategic Plan for 2023 to 2027, Ottawa Public Health Submission to Health Canada on potential amendments to cannabis regulations, and 2023 Operating and Capital Budget Q1 Board of Health for the City of Ottawa Health Unit Status Report be received and considered.
Is that carried? Thank you. So we'll now move to the consent agenda. Just again, for those who may not be familiar with the process, I will list each item on the agenda, and for any items where board members don't have any questions, concerns, or motions, and if we don't have public delegations registered to speak, the board may carry or receive those items on consent, which means to say without any discussion. So, item 8.1, Chair of the Board of Health Verbal Report. We're going to hold it for my verbal. 8.2, Medical Officer of Health Verbal Report. We will hold it to hear from Dr. Etches. 8.3, State of Ottawa's Health 2023 update. We will hold for a staff presentation. 8.4, Ottawa Public Health Strategic Plan for 2023-2027. That will also be held for a presentation, and we have a public delegation on that item. Item 8.5, Ottawa Public Health Submission to Health Canada on potential amendments to cannabis regulations. Is this item carried? Thank you. Item 8.6, 2023 Operating and Capital Budget Q1 Board of Health for the City of Ottawa Health Unit Status Report. Is this received?
Hold, please.
We're going to hold it? Okay, we'll come back to that at the end. Thank you. So we will go back to the first held item, which is my verbal report. So as we've discussed, June has been designated National Indigenous History Month. It is a reminder to acknowledge and celebrate the contributions that First Nations, Inuit, and Métis peoples have and continue to make to our communities, Canada as a nation, and to Turtle Island. It is a time for each of us to explore the gifts that First Nations, Inuit, and Métis peoples present to us through their beliefs and cultural practices that have strengthened communities for generations. Societies thrived on respect for others, caring for people, elders, children, two-spirited people, and those with activity limitations, being welcoming and inclusive and respecting and caring for the land, the animals, and the environment. The month of June reminds us to reflect on what we can do as an organization that can effect change. Call to action number 22 has special significance for OPH. We call upon those who can effect change within the Canadian healthcare system to recognize the value of Aboriginal healing practices and use them in the treatment of Aboriginal patients in collaboration with Aboriginal healers and elders where requested by Aboriginal patients. We are also called upon to support a decolonized approach to the collective response to the missing and murdered Indigenous women and girls' calls for justice based on substantive equality or true equality in outcomes to address historical disadvantages, intergenerational trauma, and discrimination. Une date importante du mois est le 21 juin. Elle marque l'arrivée du solstice d'été. This date is also culturally and historically significant for many cultures of the world, particularly the Indigenous peoples. Many Indigenous societies throughout history gathered on this date to conduct traditional rituals of prayer, thanksgiving, and celebration. This is why June 21st is the ideal day to recognize and celebrate the unique heritage, diverse cultures, and outstanding contributions of First Nations, Inuit, and Métis people. Au cours de ce mois et tout au long de l'année, réfléchissons aux moyens les plus concrets par lesquels SPO peut contribuer à l'amélioration du bien-être de tous les peuples indigènes. I would also encourage everyone to take some time during National Indigenous History Month to read the United Nations Declaration on the Rights of Indigenous Peoples, the Truth and Reconciliation Commission's calls to action, or Wabano's Share Your Story report, and imagine what you can do as an individual and what we can do as a board to advance Indigenous rights. Just before the launch of National Indigenous History Month, the Ottawa Aboriginal Coalition held a community gathering at City Hall. This event was an opportunity to bring together Indigenous community members and local partners to share the story of the coalition over the past 3 years. This story included a very special acknowledgement by the coalition of Dr. Etches and the many ways in which she ensured the safety of First Nations, Inuit, and Métis communities in Ottawa during the pandemic, including Indigenous elders, organizations, and their employees. Dr. Etches was recognized for her quiet humility and commanding voice, for her patience and advocacy, for always showing up and taking the time to listen and learn from community, and for understanding the critical importance of nurturing relationships. The coalition believes that Dr. Etch's committed efforts and leadership will result in the positive system changes that the urban Indigenous community is looking for. As part of the heartwarming recognition ceremony, Dr. Etches was wrapped in a beautiful blanket. In many First Nations cultures, presenting someone with a blanket is a symbol of friendship, respect, and honoring an individual's strengths and contributions to community. In response, Dr. Etches reinforced that OPH will continue to work in partnership with First Nations, Inuit, and Métis peoples, communities, and organizations to promote social justice and advance Indigenous rights and self-determination. Je tiens à remercier la Coalition autochtone d'Ottawa d'avoir reconnu et honoré Dr. Etches de cette manière. Je partage leurs observations sur son humilité tranquille et sa voix imposante, sa patience et son action de revendication. I also want to thank Dr. Etches for her commitment and dedication to listening to and working in partnership with Ottawa's First Nations, Inuit, and Métis communities. Congratulations and miigwech. Thank you. June is also Seniors Month, a time to celebrate the older adults in our lives. En tant que citoyens engagés, les personnes âgées soutiennent nos communautés par le biais du leadership, de l'emploi, du bénévolat, de la garde d'enfants pour leur famille et de la prise en charge d'une personne dans leurs besoins. Through our One City, One Team approach and working with partners, our collective efforts support Ottawa as an age-friendly and caring community that values older adults' contributions, offers a broad range of opportunities for active living, and provides supports that are responsive to older adults' diverse needs and choices. I encourage everyone to take the time this month to thank the older adults in their lives for their past and present contributions to our families and to our communities. Last Tuesday, I had the pleasure of attending the Association of Local Public Health Agencies annual general meeting and conference in Toronto, along with members Banham and Brown-Shrevs. The morning featured 3 guest speakers, all on the broad theme of post-pandemic recovery and renewal. This was followed by the Alpha Business Meeting and Resolution session. In the afternoon, we participated in an Alpha Strategic Planning session, and then we heard from Dr. Kieran Moore, Ontario's Chief Medical Officer of Health, on the topic of emerging successfully from the pandemic. Because I had to return to Ottawa for a city council meeting on garbage, I was not able to stay for Wednesday morning's Board of Health section meeting, but members Banham and Brown-Shrevs did attend on behalf of our board, so I'm going to ask member Brown-Shrevs if she wanted to share some reflections.
Thank you. So for the morning session, we had 3 main topics that we discussed. So public health and political landscape, We also spoke about workplace health and wellness. And finally, exploring the intersection of primary care with public health. That was, quite an interesting and informative conversation, a well-needed one. We spoke about the various ways that primary care intersected. We talked about family medicine, how it's all about continuity, and that there's always people behind some of those stories that that we'll hear in community, and how it's important that public health recognize those stories behind the numbers for the data that we collect. We also mentioned that what public health has identified as priorities, that it should be useful for professionals within the community. So it's very important that public health work together, very closely with primary care partners, recognizing that we are strong allies. And as such, we need to, work with family medicine champions. We need to bring family docs to the table to do this work collectively. So those were some key takeaways from the morning session.
Great, thank you so much for sharing. And this was really just a brief overview. So pursuant to the board's travel policy, we will prepare a more detailed update through the information previously distributed memo to be listed on our September board agenda. But I would like to thank members Banham and Brown-Shrevs for taking time out of their very busy schedules to participate. It is a great experience, both for learning and networking, and I encourage all board members to avail themselves of this opportunity at least once during their term. Je tiens aussi à remercier le personnel de SPO qui a préparé des notes d'information sur chacune des résolutions examinées par les délégués de l'ALPHA. Ces informations nous ont aidés à orienter nos votes. Alors, merci beaucoup. Finally, I wanted to share that Dr. Etches and I do meet regularly to discuss various issues and topics that are top of mind, and I know she will be talking more about this as part of her verbal report. But I wanted to take a few minutes to talk about the budget pressures OPH will be facing as we head into this fall and the process of developing the draft 2024 budget. As board members know, OPH's main funding sources are the province of Ontario and the City of Ottawa. To date, the province has provided up to 75% of funding for public health cost-shared programs, with the city providing the balance. Originally, the provincial contribution was through base funding, and since 2020, it has come through a temporary 5% top-up in mitigation funding to offset the change they announced in 2019 to a new 70-30 cost-shared funding formula. That temporary top-up funding will not continue past this December, and the province has not indicated what its funding plans are for 2024. What this split in public health funding does not fully recognize is that, unlike the province, for the past many years, the city has been providing annual inflationary increases to OPH's base budget, thereby increasing its proportional contribution. Further, the city also provides approximately $9.9 million worth of in-kind supports to OPH annually in terms of facility management, human resources, and labor relations management, information technology, legal and financial services, and more. This means that even before the province's unilateral change to the funding formula, the City of Ottawa was already contributing more than 30% towards public health. Our challenge is to get the province to recognize the true value of the city's contribution. Je continuerai à travailler avec le bureau du maire et de nos collègues provinciaux pour trouver des solutions à ce déficit de financement. We look forward to engaging with provincial elected officials on this topic at the Association of Municipalities of Ontario meeting in August, which I will be attending. That concludes my verbal report, and I would be happy to take any questions. Seeing none, Dr. Bauer? Or Brent Bauer, sorry, Member Bauer.
Not quite a qualified doctor, thanks.
There's so many doctors here.
But thanks, Madam Chair. And I guess my question, I was intrigued to ask it around the budget item, but perhaps I can ask it now, is I read with interest in the communications package the letter from the Mayor of Hamilton to the Premier on the funding issue, on the split and the mitigation funding. And I wasn't sure, just because I'm very new, if the board or the council or the mayor have we passed any formal motions in that regard or drafted letters formally to communicate our desires around maintaining the split as it was?
Yeah, so there's probably people that can give additional historical context, but towards the end of the last term of the Board of Health, there was a motion here, and then it was brought forward to council, and we did write the letter from the mayor and from myself with that request.
Okay.
So.
No, that helps, thanks, because I know we're working the back channels as well as possible, so it's good to see that visibility as well. Thank you.
If there is interest, we can always, look at sending another from this new board. I don't know, Dr. Etches, if you wanted to weigh in on that at all.
I think you'll hear in my note as well, we're still thinking of all the scenarios and the possibilities and the service impacts that might result. So it may be useful to write to the province again when we have more information about the impacts on our service, rather than repeat the same message. But it's up to you.
Yes, ultimately it resides with the board, but that might be something we want to discuss at the September meeting as well. Thank you. Is there any other questions? Seeing none, we will proceed to can we receive the report? Thank you. We will now proceed to item 8.2, Medical Officer of Health Verbal Report. Dr. Etches?
Thank you, Kwei, Unesakut, Annie, bonjour. And I also want to thank the elders for being here and opening our meeting. And I want to recognize Rob Chief, who is here, and Kimberly Trotter, who is not here, who are really instrumental in continuing to help Ottawa Public Health as a whole learn how we should be working to promote Indigenous health. And I just want to thank them both for their work, and Rob for being here today as well. Miigwech. So I'm going to speak a bit more about the budget, but that's at the end. So first, a number of subjects that we'll go through. And I want to start with the U.S. Surgeon General, which recently issued an advisory highlighting the mounting research about the harmful effects of social media, and particularly on mental health, including negative impacts to body image and the contribution to the development of eating disorders. Les médias sociaux et l'utilisation de la technologie font désormais partie intégrante de nos vies, et malgré le fait qu'ils présentent de nombreux avantages, leur utilisation excessive peut être associée à des problèmes de santé mentale tout au long de la vie, avec un impact particulièrement négatif sur la vie des enfants, des adolescents et des jeunes adultes. So in the U.S., as part of the Surgeon General's advisory, it was found that youth who use social media for more than 3 hours a day faced double the risk of depression and anxiety symptoms. This is of concern because the average amount of time that American children use social media is 3.5 hours a day, above that threshold. And recent results from here in Ontario, the Ontario Student Drug Use and Health Survey, showed that in 2021, 3/4 of Ottawa students reported engaging in more than 2 hours of recreational screen time, including social media use each day. So daily recreational screen time was significantly higher among Ottawa students grades 9 to 12 compared to 7 to 8, and was also higher among people who identified as socioeconomically disadvantaged compared to people who are not. And as a result of these findings, taking a look at our local data with our clinical partners at CHEO and others, Ottawa Public Health has been working in the community and with local school boards to build resiliency among youth and promote alternatives to screen time. We're working with our school boards to embed content related to screen time and social media use into the youth engagement programming in high schools. So this is youth-to-youth work, peer-to-peer, a program called Youth Connections Ottawa. We're also embedding content into our mental health promotion work in elementary schools, and that's our Healthy Transitions work. As part of our outreach, we work alongside local partners to develop resources that highlight the impact of screen time on the healthy development of children, and it includes helping parents and caregivers identify the signs that children are having difficulty coping and suggesting ways for them to model healthy behaviors. Parents and caregivers are provided with tips on where and how to access supports and services. And working with experts in this field, Ottawa Public Health is ensuring that parents and caregivers do have timely access on multiple channels, including through our neighborhood health and wellness hubs in person and our Parenting in Ottawa Facebook page. We can all take steps to reduce the negative impacts of social media. I think it's fair to say probably all of us, on ourselves and our families. And some key actions we can take are to have device-free periods, device-free spaces in our homes, putting devices away during family meals and activities, as well as storing devices in dedicated spaces. These are all practical tips, and we can model these best practices also by limiting our own time on social media. Of course, we see the benefits as well, and we want to find a balance between building healthy in-person connections and that engagement online. So we'll continue to be working on this topic. Next, I want to talk about Get a Kit initiative. And this happened during the pandemic, but we didn't get to it. We were talking about COVID so much to let you know it was happening, and it's expanding. So in July 2020, Ottawa Public Health partnered with the University of Ottawa's Nursing School to launch Get a Kit, Canada's first at-home HIV self-testing programme. L'objectif de ce programme était de rendre plus accessible le dépistage de VIH à un moment où les mesures de distanciation physique étaient en vigueur et où le dépistage en clinique n'était pas possible. So since launching, Ottawa Public Health and Get a Kit have not only expanded access to screening for other sexually transmitted and blood-borne infections, but the initiative we are seeing is reducing stigma. People are coming forward to get these test kits who haven't been otherwise accessing tests. It's shortened the time from diagnosis to treatment, and it's reached people who were previously, as I said, experiencing barriers in testing and treatment. So nearly 1,600 test kits have been distributed to Ottawa residents, and more than 8 in 10 receiving the tests belong to the groups most affected by HIV. So additionally, more than 1 in 5 people who have used the HIV self-testing through Get a Kit identified as being African, Caribbean, or Black, or as Indigenous. So in an expansion now of this research initiative between the fall until May, we've been partnering to validate at-home self-swabbing for oral and rectal gonorrhea as well as chlamydia. And we're working with the Public Health Ontario laboratory to have this test accredited. And so once approved, the at-home self-swabbing for gonorrhea and chlamydia could be expanded province-wide, enabling faster and easier access to testing for many people across the population, including disproportionately affected populations of men who have sex with men, bisexual, trans, and gay men. And lastly, what we're working on now is adding urine testing for gonorrhea and chlamydia to the options provided through the Get a Kit West. Oh my, I'm having trouble with the language here. Get a Kit test website. We're looking to have syphilis testing added. So this will be an important expansion given the rise in syphilis that we're seeing. And so this test is available to anyone in Ottawa between the ages of 18 and 49. And then we'll begin more public promotion of this as we're able to expand. So on our dental clinics, you heard a bit about our dental programming last board meeting. I wanted to let you know that the Merivale Road is closed for about 6 months because we're expanding the number of operatories from 7 until 11. So we are growing our capacity there. And while it's closed, our clinics on Cobourg and Saint-Laurent remain open. Nos cliniques de la rue Cobourg et du boulevard Saint-Laurent restent ouvertes pendant cette période, tant pour les rendez-vous dentaires que pour les urgences. And I want to congratulate the team, because this is not a small feat either, that last week they implemented a new digital system for dental x-rays. So we're very pleased that we're continuing to work with the city's IT department. We're seeing this progress in the implementation, and then it will link to that electronic public health record we were looking for in the fall. I'll touch on extreme heat and outdoor air quality. That was hard to miss since our last meeting. We've experienced a number of days with very high temperatures, as well as unprecedented levels of polluted air coming from wildfire smoke in northern Quebec and Ontario. So the City of Ottawa has a plan to deal with extreme heat, cold, and smog, and this plan outlines the actions that would be taken by various community members and organizations, including Ottawa Public Health. La Ville d'Ottawa a un plan pour faire face à la chaleur et au froid extrême, ainsi qu'au smog. So this is aligned with a provincial system as well, just so you're aware that it's provincially that heat warnings and processing of data occurs. So the plan is activated when Environment and Climate Change Canada issues a heat warning or if there's an advisory about air quality. And then what Ottawa Public Health works to do is disseminate information about the warning to make it more visible and help people understand what it means for them. We do that through social media. We also reach out directly to community partners and service providers who work with priority populations. So populations that could be at greater risk of negative outcomes. And we also do see the city, this is part of the plan that we work with them to convert the public pools to leisure swims so that people have a place to cool down. It's another option. We ensure that community partners are proactively distributing information to the priority populations and that 311 and 211 have that most updated information to support people to know where they could go to cool down. The homeless shelters, we make sure that they're using their air-conditioned and clean air spaces as indoor refuge for clients. And we also know that Ottawa Community Housing and the managers of other buildings where there are low-income housing, groups of buildings and individually where there are higher populations, that they open cooling rooms for residents who don't have access to air conditioning. So we'll continue to work with the City of Ottawa's Emergency Management Office and the Community and Social Services Department through the events to see how this notification and awareness raising is going, how the access is going, and if there are impacts that require greater interventions. And if there was more challenge, then we would move to the city activating their Emergency Operations Center. I'll turn to immunization, another topic that you, I know, care very much about. We are continuing to help children and youth catch up on their routine vaccinations. Nos cliniques de vaccination familiale et communautaire et nos centres de santé et de bien-être de quartier dans toute la ville continuent de donner les vaccins de routine pour les enfants. So children and youth who do not have a regular healthcare provider or who cannot easily access vaccines through their regular healthcare provider are able to attend our regular family and community vaccination clinics for any childhood vaccine. And we're proactively asking people who come in for COVID or other vaccines as well. We're going through the list of things they might need to catch up on. And we've also begun, where there are neighborhoods with lower coverage, to actually go to schools, select elementary schools, and hold vaccination clinics in schools. We've mailed out notices to parents of children born in 2005 and 2015 where their record is showing an immunization was missing or there's incorrect information. And we're using more technology now to reach all children, households with children whose records show an immunization is missing or where there's incorrect information. So we have the technology to use email, text, and voice messages. And then finally, we are excited to be working with Kids Come First to team up on a campaign that's also raising awareness, try to get people out to these clinics, vaccinate and up-to-date campaign. It is many partners making it easier for children to catch up on vaccinations. And part of the clinic process is also piloting a new Can Immunize Clinic Flow program, which allows us to have a centralized booking system This is pretty exciting. I know it's like multiple organizations using a centralized booking tool to make it simple for families to, access vaccination through multiple agencies. And then that also puts the information routinely, seamlessly into the Can Immunize app for their record. So progress there. We'll touch on thinking ahead to the fall respiratory illness season because we won't meet again until we're into September. I want you to know that we are expecting that the fall influenza respiratory virus COVID RSV season will be probably somewhat similar to the one we experienced last year, which means challenging. Earlier influenza, RSV still higher than usual. And so in preparation, Ottawa Public Health is developing a public communications campaign. It will launch in phases, so we're aware that people aren't listening as much right now about respiratory illness. So it's more with the back to school sort of season that will target messages, not just to the parents of young children, but also to those who are older adults, immunocompromised, where we want people to be encouraged to continue to understand what they can do to decrease the harms from transmission of respiratory viruses without, striking a balance to make sure that we don't lose the social connections that are so important, particularly for people who are at risk of social isolation. L'objectif est de trouver un équilibre dans nos messages entre les mesures que nous prenons qui visent à réduire la transmission des virus respiratoires et le maintien des liens sociaux qui sont également importants, surtout pour le bien-être des personnes âgées et de celles qui sont exposées à un risque élevé d'isolement social. And a little update as well, for those who are at high risk of serious illness, who need to access antivirals, potentially for treatment, the Ontario's Chief Medical Officer of Health informed us that the provincial rapid antigen test public distribution program, as it was, will be winding down at the end of this month. But to support ongoing access to COVID-19 testing for people who may, as I say, need that treatment, and into the fall of 2023, the province has asked that local public health units make rapid antigen tests available through our existing services or through partners, and so this will be while provincial supplies last. And we are developing a distribution strategy, so we'll update you as the details become available, but obviously before the end of the month. We're getting there, just 2 more topics. So on integrated planning, this was the work that Ottawa Public Health took, seriously rethinking how do we want to go forward. Over a year, we were collecting information from community and employees across the team to think about how we can use the lessons learned from our pandemic to better respond to our community's evolving needs. And this did allow us to identify, almost $9 million in resources that we wanted to shift to do things differently. And so we reinvested in priority areas identified by our team and by community members. And a key lesson from our pandemic response is that some populations bear the burden of illness and disease more than others. I won't dwell on that. I think you'll hear more about that actually from others today. And that's why, as we are resuming our routine operations, we are devoting more resources to improve the health outcomes of disadvantaged neighborhoods and racialized populations. In particular, we're focusing on supporting people from African, Caribbean, or Black communities and Indigenous communities who face the greatest barriers to accessing health and social services. That reallocation also is about increasing our resources to support infection prevention and control and work to prevent and manage disease outbreaks, which are continuing at a high volume. The lengthy review that we undertook brought together multiple work streams into this integrated planning process, and it included the development of our 2023 budget, which you passed, and the next 4-year strategy, which is before you tonight. It also involved this workforce plan to redeploy staff to areas of the organization where needs are greatest. And it was driven by a few things, including the operational context that provincial funding for COVID-19 is ending at the end of 2023. That means we are continuing to demobilize our pandemic response. And you can see that in our budget Q1 update. So we are spending less on COVID to this point in the year than what would have happened if we just maintained our response. So it continues to come down. We also recognize that workload pressures on staff. We're continued to hear that some teams were really continuing to struggle with maintaining a reasonable workload, and so that reallocation to the infection prevention and control and communicable disease areas. And then the work to focus on health equity meant that we wanted to continue that neighborhood-based work, and so that is part of the health equity work. It's not all of it, but you could see these guiding principles coming through in the strategy before you. So I think with the COVID funding, you can see that means we have to build any ongoing pressures into our base budget, and that will be a pressure as the COVID is still here, and I mentioned the outbreaks continue. But we will bring you more details on scenarios for 2024's budget in September. I think what we know is that we're going to face these budget pressures into 24, and so we want to provide you with more detail. I think you heard from the chair there's still some uncertainty, so we'll look for more clarity from the province in August. We really haven't heard how the province is planning to respond to the letters that they've received, but we anticipate that. And so I guess in the meantime, we'll continue to seek that clarity. And I want to finish by also some good news, considering that we're spending so much time talking about finances, that today we have a new member of our Ottawa Public Health Senior Leadership Team. I want to introduce you to Dr. Mohamed Kibria. So he's waving over there. This is his first day, so thank you for printing up a nameplate, whoever got that done quickly. Kibria, as he likes to be called, is the new manager for the Medical Officer of Health Business and Development Support Area, which includes oversight of finances and human resources. And he comes with not just the corporate services expertise, but a PhD in health policy and a master's degree in public health. And so he has served as an executive director in previous roles, and we're very fortunate he will be overseeing our financial strategy, our human resource strategy, and helping with some of the complexities that we have where we know that Ottawa Public Health alone cannot move the bar on everything that affects the health of our community, and we need to work across organizations. So some of that complex project management oversight as well. So we appreciate that. We'll keep privacy concerns also handled well, as well as our student and volunteer placement and looking at internal communications. So thank you very much. Welcome, Kibria. We want to thank you. And I also want to end by thanking Joanne Henderson-White. So Joanne has been very hard at work, not only advancing health equity, but overseeing these corporate services for the last year, pretty much. And so, un gros merci, Joanne. Merci beaucoup. I know that Joanne will continue to provide leadership and support as a senior leadership team member, but able to dedicate her time fully to Indigenous rights and well-being and the health equity, diversity, and inclusion work. So glad for that too. So that's all. I'm happy to take any questions.
Member Bauer?
Thanks, Madam Chair, and thanks, Dr. Etches, for that comprehensive report. I was very pleased that you touched upon the Get a Kit initiative. That's been a real success story for Ottawa Public Health and with the University of Ottawa, and especially with community groups who helped develop that and promote it. And I was pleased to hear about the innovations that are happening to enhance the testing range for the kit. One that you didn't mention was the recently approved rapid test saliva for HIV. And I'm just wondering, because from my recollection, Get a Kit was blood testing, and that has barriers, and I think this rapid test saliva for for HIV has the potential to be a real game changer to get us to our 90-90-90 goals and in the pandemic. So I'm just wondering if that's part of it, because I know it's been piloted out of St. Mike's in Toronto, and I just want to make sure that Ottawa isn't left behind in that initial rollout.
Thank you, and you're right to recognize the community organizations that have helped promote this. Patrick O'Byrne is pretty up to date on all of the tests that we should be adding, even as they come out. So I can double check with him, but I think he will want to do as you suggest and make sure there are all the options possible.
Thank you, Member Bauer. Member King.
Thank you, Chair, and I want to echo what Member Bauer was talking about with the Get a Kit that I literally saw last week at a community event with the racialized and Black community, that people were talking about this kit, and I was really impressed. So I think that it's gotten great reception in the community, and I wanted to relay that to you, the excitement of seeing a middle-aged grandmother holding the kid and saying, we have this tool in the community, I thought was really impressive at one of the anti-racism secretariat meetings. And so I felt that there was great impact with that kit, and a great impact of OPH in the community generally. You know, I was at a block party in my ward, and I saw the OPH booth there, and I thought that this was great, that the direct outreach to the community is quite impressive. I did have one question, and I don't know if OPH has the data or has had discussions about this, but I was just curious about the impact of the wildfire smog that the city saw over the last couple of weeks. I know that, you know, we're going to have continuing challenges around climate resiliency, and so I was just curious whether there was more hospitalization or other impacts that we saw because of the wildfire smog, and whether we are accounting for these types of conditions in the future.
Yes, thank you for that question. Indeed, we were monitoring in real time hospital emergency room visits for respiratory-related illness. And that is, I mentioned to Cameron McDermott there, a senior epidemiologist, if he wouldn't mind coming forward to speak to it further. But what we saw was as the particulate matter in the community went up very rapidly on that first day, that day there were a greater number of emergency room visits due to respiratory illness, sort of unspecified. And then as the particulate matter stayed high and even went higher, we actually didn't see that continued rise of respiratory illness. And we will continue to learn from this. We'll continue to monitor. That the literature suggests that you would expect to see greater number of admissions. It does exacerbate respiratory illness and even cardiac illness. So we're hoping that it was so bad that people stayed indoors, like they got the message, and maybe that actually protected some people. But I don't know if you want to add, Cameron? No, that's got the thumbs up there.
No, well, thank you for that. I saw the expedited communications both out of the city and from Ottawa Public Health, and I think that did make an impact. But obviously, I think as we have these challenges due to the climate issues that we are going to face in the future, I think that we have to continue to keep it top of mind. But I appreciate the hard work that was undertaken with the communications. Thank you, Chair.
Thank you, Member King. I think that's a great point. Just a huge congratulations to the OPH team for the great work on air quality and getting the message out. I think everybody in the city really benefited from it. I'm not seeing any other hands, so can we receive the verbal report? Great, thank you. So item 8.3, State of Ottawa's Health 2023, an update. We do have a staff presentation. We'll invite Cameron McDermott back, senior epidemiologist, and I believe he'll be joined by Dara Spatz-Friedman. Maybe not? Okay, sorry. Reading off my notes here.
Thank you. My name is Cam McDermott. I'm the Senior Epidemiologist with Ottawa Public Health. I'm joined online by my colleague, Dr. Dara Spatz-Friedman, And accompanying me today is Cameron Keys, who's helping me with the slides. So I'd like to start off with a land acknowledgement. Ottawa is built on unceded Algonquin and Anishinaabe territory. The people of the Algonquin and Anishinaabe Nation have lived on this territory for millennia. Their culture and presence have nurtured and continue to nurture this place. The City of Ottawa honors the peoples and the land of the Algonquin Anishinaabe Nation. So when we start off with health reporting, there's a question about why Ottawa Public Health does this work. And it's a mandated activity under the Ontario Public Health Standards, but more importantly, it's one of many ways that OPH helps plan and enhance programs and services, identifies strategic priorities, identifies gaps and monitors changes in the health of people living in Ottawa, as well as to some extent assisting with the evaluation of the health impact of different policies. Also as well, this and other tools provides a way to transparently report health issues to the public. In the presentation today, we'll be covering a number of different topics listed here. Changes in demography, what's happening in the city, social determinants of health and their impact on health equity, mental health and substance use health, chronic disease, injury, and health-related factors, as well as infectious disease. This is a big topic, so we'll be sort of touching on the high points that are contained within the report in the presentation today. So taking a step and looking at the City of Ottawa, we're seeing it's increasing in size and diversity. Since the last census, the city's Ottawa's population has grown by about 17%. Ethnic diversity has continued to increase from 28% in 2016 to 35% in 2021, a 7% increase. When we say ethnic diversity here, we're talking about the census measure of visible minority, which is based on the Employment Equity Act. We're anticipating that Ottawa will continue to grow. Most of this growth will happen in the 20 to 49-year-old age group, as well as people aged 65 and older. So by 2030, an estimated 1 in 5 people will be aged 65 or older in Ottawa. This has implications for services. It has a lot of implications for thinking ahead to see what our population will look like for the next 10, 20 years. To see that a little bit more visually, if we look at a population pyramid, and here we're seeing bars which represent number of people identifying as male and number as female on the right-hand side. The blue bars are where we're at now, and the green line represents 2030, so you can see that most of this age growth is anticipated to happen in these two age groups. When we're talking about health, we're talking about things that are influenced by things other than people's healthcare or individual behavior. And this isn't a news story. We're talking about things like low income, systemic racism, lack of adequate housing. All these things and many others shape the health inequities in our society, and these things are outside the realm of personal choice. When we look at how we measure these things in reports like this, we're somewhat limited, but we do get data from population health surveys that include individual information where people are reporting their income, their education, that sort of thing. We can also coalesce a lot of that information spatially or within geographic neighborhoods or areas and to describe a level of advantage. So in the presentation and in the report, you'll hear about quintile 1, quintile 5, high advantage, low advantage. Those are examples of that latter measure. A lot of the things we do, particularly when we're talking about people's health status, so if we look at things like emergency department visits or hospitalizations, social determinant data is largely missing from that sector. So we don't have a lot of information when we're talking about this, other than an approach that uses a geographic area, which has some limitations to it. So some examples of social determinants of health in Ottawa. Some of these are advantages, some are not. Almost 9% of people live in Ottawa, or in Ottawa live in low income. This depends a little bit on the measure you use. Here, this is the low income measure after tax. But there's other ones, low income cutoff, market basket measure. There's a lot of complex tools we can look at to assess people's income and income status in Ottawa. Just over 3/4 of people in Ottawa have a post-secondary education. 42% of renters are paying 30% or more of their household income on shelter costs. And 13% of households in Ottawa face some form of food insecurity. When we look at how these things play out in terms of impact, COVID has a really good and recent example to sort of underpin how these things affect people's health. When we look at rates of COVID in the least advantaged neighborhoods, we're more than double that in the most advantaged neighborhoods. The burden of health was also higher. Hospitalization and death rates were almost 3 times higher in the least advantaged neighborhoods, and neighborhoods with the most advantage generally had higher levels of COVID-19 vaccination. All these things vary a little bit depending when we're looking at in the course of the pandemic, and we'll show that to you graphically now. When we look at COVID rates, what we're looking at here is 3 blocks of time. Pre-vaccination, starting in about July of 2021, where we're talking about 60% of people who are vaccinated, but we're still talking pre-Omicron. And then from January 2022 onward, where we're talking about post-Omicron. So within each of these blocks, on your reading left is the highest advantage neighborhood, and on your reading right, the lowest advantage neighborhood. And pre-vaccination here isn't entirely accurate. There was vaccination available, but it was only restricted to very small groups early in 2021. So from here, we can look at the size of these gaps, particularly early in the pandemic, where there was a phenomenal difference in the burden of health with regards to COVID infection. This was attenuated a lot in subsequent periods as vaccination came online. If we look at the health burden piece as well, here the divisions are the same reading left to right in terms of what time periods we're talking about. The dark blue purple bar is hospitalizations, the lighter one is deaths. And again, reading left to right, highest advantage to lowest advantage on the reading right. We see that this effect is still present, again, most markedly in the first parts of the pandemic, but it is persisting throughout. This isn't the only example of where social determinants play out. And if we look at some other measures, we can be talking about people's rating of self-rated mental health and general health that are generally lower in people who have low income. Hospitalization rates for diseases that represent the highest hospitalization burden are between 15 and 30% higher in low advantage neighborhoods. And we'll see this graphically a little bit later on. Other determinants that are important, over 1/3 of people who've immigrated in the past 10 years do not have a regular health provider. So we're seeing how these things play out in some of the antecedent pieces, like access to healthcare, income, all these things interact to affect health equity. Changing a little bit to talk about mental health and substance use health. 60% of people living in Ottawa rated their mental health as very good to excellent. This is an estimate that was taken from data from around 2019 to 2020. So just sort of at the start of the pandemic, it did represent estimates that were a little lower than historically. And throughout the pandemic, Ottawa Public Health did population surveys to look at the impact of COVID-19 on people's mental health, and it was pretty clear that there was decreased self-rated mental health. In other venues, when we're talking about things like substance use health, we could see the impact of the pandemic on emergency department visits and deaths that were associated with opioid-related overdoses that more than doubled. So if we were to have a look at a number of different measures over the course of, from 2016 onwards, the top purple line represents emergency department visits, followed by hospitalizations and deaths below. But you can see right away that there's something going on at the end of 2019, 2020, where if you were to sort of eyeball what those lines look like, you'll see a massive shift upwards of hospitalizations. It's not as apparent at this scale for deaths, but we did see that similar doubling of health impacts related to opioid overdoses during the pandemic. Unfortunately, this has been persisting and hasn't dropped back downwards. Talking about chronic disease, injury, and health-related factors, the most common self-reported conditions are arthritis, high blood pressure, anxiety disorders, and mood disorders. When we're talking about an older population, we start to see the appearance of things like heart disease and diabetes, things that result from chronic exposure to health factors. When we look at these measures, we often will use things like emergency departments, hospitalizations, and deaths as proxies for what's happening in the community. Unfortunately, we didn't receive updated data on mortality or death data until a couple of weeks before the report was ready, so we'll be looking at reporting that in the future. But if we're to look at emergency department visits, we see that injuries are the leading cause of emergency department visits. And within that group, 39% of those are associated with falls, and 70% of hospitalizations associated with injuries are also related with falls, which highlights the importance of this as a public health priority within injuries particularly. Falls are a leading cause of injury-related hospitalizations across the lifespan, except for people aged 15 to 44, where self-harm becomes more evident. This isn't a new story. This is something we've seen in previous reports. When we take a bigger step back and look at the leading causes of hospitalization, these are some of the more systemic things we would expect to see: cardiovascular disease, effects of diabetes, renal failure, colitis, hepatitis, digestive disease, for example. So these big categories are what cause the lion's share of hospitalizations, but as I said earlier, there is a big health equity disparity here. When we look at hospitalizations related to neighborhood advantage, here we're looking at each of these categories with the dark purple representing the neighborhoods of highest advantage, and on the right, the ones of lowest advantage. And you can see for pretty much all of them, there's this disparity between 15 and 30% of the population rate of admission to hospital for these conditions. There's a number of other things that affect health. Smoking rates continue to decline, which is an important story. Vaping in youth is estimated around 9%, which is somewhat below the provincial estimate, but still an important measure to be keeping our eye on. Just over 2 out of 3 people 19 and older are at no or low risk of alcohol-related harms. Just over 2/3 of adults report meeting the physical activity guidelines. 40% of children were active 3 days or more per week, and just over half of grades 7 to 12 students reported 5 or more active days per week. At a population level, about 58% of people aged 18 or older would be classified as overweight or obese based on their height or weight. And cancer screening decreased in 2020, probably because of the effects of COVID and access to health services. OPH also monitors many groups of infectious disease, and these diseases can be grouped in a number of different categories: direct contact and respiratory diseases, sexually transmitted and bloodborne infections, vaccine-preventable diseases, enteric, foodborne, and waterborne diseases, and vector-borne or zoonotic diseases, those diseases that are carried by insects or animals. If we look at each of these groups, we can see that latent tuberculosis, which is a tuberculosis infection but no active disease, is one of the largest groups that OPH looks at. Missing from this list is COVID-19. And to give you some context of scale, when you look at some of these numbers, when we look at COVID-19 throughout the pandemic, over 92,000, almost 92,000 people, have had a lab-confirmed infection with COVID. Over 3,800 were hospitalized due to COVID-19, and over 1,000 people died due to COVID-19. It's still in the community, and it may not be as bad as it was, but it is still an important pressure for public health. When we look at some of the other diseases here that stand out, Mpox response and management, particularly, there was a global outbreak of Mpox in 2022. 40 people were diagnosed in Ottawa, and through vaccination outreach efforts, over 4,600 people in Ottawa received a first vaccination for Mpox, with about 38% of those receiving their second dose. Looking at sexually transmitted and bloodborne infections, chlamydia and gonorrhea, both as is typical, are sort of leading the packs here. We did see less disease in 2022 than we had seen pre-pandemic, but unfortunately those numbers are starting to rebound a bit. Vaccine-preventable disease, strep pneumo, invasive streptococcus pneumonia is the most common. And fortunately, we haven't seen any of the ones we were worried about at the start of the year with things like measles and some of the vaccine-preventable diseases that are maybe more at risk in kids. Looking at enteric, waterborne, and foodborne disease, most of the reported disease are from 3 specific diseases: salmonellosis, Campylobacter enteritis, and giardiasis, make up about 65% of all people reported with enteric, water, or foodborne disease. Similar to what we saw with sexually transmitted and bloodborne illnesses, there were fewer people reported in 2022 than we might expect compared to pre-pandemic periods. Looking lastly at infectious disease, vector-borne zoonotic disease, Lyme disease was the most common. There was 1 report of West Nile virus and 1 of Q fever in 2022, but the bulk of the diseases are falling within Lyme disease, partly because black-legged tick, the carrier, is now endemic to the Ottawa area, as well as improved detection. So when we look at all these things and we think about how we measure them, we have to keep in mind that population health assessment is really a process. It's continuous. We continue to monitor and to report to support programming, strategies, partners, policies, and the general public's knowledge. We're also working hard to continue and improve collection of data, particularly with reporting to a social determinants lens. I mentioned at the outset that a lot of these measures aren't really baked into some of the things we use. So Ottawa Public Health has been working very hard, along with provincial partners and local partners, to improve the collection of that data. And I also want to add about the piece of continuing to engage community and partners to include qualitative data and community voices. I've thrown up a lot of numbers here, and that's part of my business, and that's how I can sometimes look at the world. But it's really important to remember that all these numbers are people. All these people have different experiences. All these people bring different contexts. So this level of engagement is really critical to understanding the work we do and looking at improving ways of getting information into the hands of people who've needed it. We've seen a lot of leveraging of technology during the pandemic with some of our dashboard reporting. We've got the inception of the mental health and substance use health dashboard, which went live recently. So we're looking at new and different ways to get information into the hands of people who need it. Thanks very much for your attention.
Thank you very much. We will go to questions if board members have any. Member King.
Thank you so much, and thank you for the tremendous amount of work that went into this in-depth report. It's much appreciated. Even if it's a requirement, we know that a lot of work took place, and it's definitely necessary to make assessments. I might be asking a technical question, but I know I'm not being precise here. And maybe it stems from the comment that you had noted that you'd be awaiting more information from Statistics Canada, I'm assuming around excess mortality. So I was just curious to get an opinion from OPH about this scenario where I know in the Canadian Medical Association Journal, they noted in terms of looking at excess mortality that an effective system response to health threats requires more consistent and more comprehensive reporting of data across jurisdictions and a collective forensic analysis of reasons for observed variations. And so I'm just curious, about that interdependence in terms of data, the data that goes back and forth, because obviously it could potentially be the public health unit in Ottawa that has to deal with the challenges that we saw emerge with COVID, with, as you had noted, people not being able to get proper screenings for cancers, et cetera. So I'm just curious about the interplay of data. I know that you're expecting data to come from StatsCan, but I'm also wondering, what do we do internally to learn about excess mortality and really address the health challenges once they're identified in the local population?
Thank you, through the chair. It's a complex question. We'll be getting information through the Ministry of Health, and have done, from 2016 to 2018, which will give us some sense of not only excess mortality, but what are the leading causes of death in Ottawa, as well as where are we seeing that burden in places we wouldn't I won't say want to see, but in terms of potential years of life lost, for example, and how those things may or may not be preventable. Some good examples of that would be smoking related. A lot of the causes of mortality require a long period of exposure to be able to show up. So one of the questions that will be happening, and perhaps not at the health unit level, will be looking at COVID as an example and saying, what was this burden and who bore it? So there'll be a lot of unpacking that will be happening, and it may not be happening at the health unit level. We may require more data from larger areas to be able to look at these questions. But I think that the same equity questions that we've seen evidenced even within the COVID data analysis we've done with Ottawa data will play out in other things. And we'll be looking at other ways that Ottawa Public Health can make inroads for prevention, whether that be early detection, avoidance of exposure of the antecedents for that disease to start off with. If you think about diseases that have a longer arc and impact on people's health, like diabetes, for example, and looking at different ways that we can augment or support a broader system.
Excellent. Well, I appreciate that answer. I know it's complex. I really asked it because I think the thing that kept me up at night during the pandemic was the reports on how many people were sick and dying. And now the thing that is preoccupying me is how many people are affected by chronic illness because they did not have the opportunity during the pandemic to get the proper health care, get the proper assessments, and the catch-up that will be required for that. And obviously the data is necessary for that endeavor. So I appreciate the work and the thought that's going on around this. And obviously when that data comes in and we have updated reports, we'd appreciate continued updates on that. Thank you, Chair.
I might just add, because I think you were also hinting there your concern about something emerging. So we don't have to wait, how many years is it now? Like many, many, many years for the formally approved and cleaned data on mortality. We have networks with our police, our hospitals, our coroner, and if there's something that's emerging that's unusual or appears to be a pattern, that is information that we use right away. And so, for example, with overdoses, if there seems to be something happening where maybe there's some cocaine or something that has fentanyl in it, that people are having a cluster of overdoses, we have a detection and response system for that. But I think also, just to underline what Cameron said, that we can see the pattern in the data related to social determinants of health and poor outcomes. And so that guides us in terms of where we need to be focusing on prevention as well.
Thank you. Member Chung, please.
Thank you. Thank you for that presentation and the report. I know it's a huge undertaking, so congratulations on getting it out. I had two comments/questions. The first one is about BMI, and I know that there's increasing discussions around BMI and how it's the cutoffs for diseases are not standard across the board for all populations. In terms of, diabetes, heart disease. For certain ethnicities, the BMI is lower, certain others are higher. I was just wondering how that will be, incorporated into future versions of the report. And my second question was about infectious diseases. I noted that the CPE was included in the presentation, but just wondering if there was any thought to including other diseases that are becoming more resistant to antimicrobials, because we know that certain diseases, they're more prevalent through travel or medical tourism, and they are becoming increasingly appearing in the community, not just in healthcare institutions. Thank you.
Thank you. Through the chair, the question around BMI is a good one. BMI at a population level, still, it's a blunt tool, certainly. and still fairly well correlated with chronic disease measures. But there are definitely questions around how well that represents not only individual variation individually, but also within different ethnic groups. So we'll be looking to the literature for the most part to try to get a better handle on some measures that maybe either require modification or maybe need to be replacing this. And a lot of that starts with the primary data collection. A lot of the information at a population level comes from a population health survey. So things like waist circumference, which would be another measure that's informative for overweight or obese status, for lack of a better word, is very difficult to do in an interview context in terms of saying, well, have your measuring tape ready, whereas most people will know their height or weight. So the collection piece is part of it. There are other surveys, the Canadian Health Measures Survey, for example, that actually evaluates and looks at those pieces. But I think the complexity you measure about how does this play out in different ethnic groups and is it appropriate, we're looking in a sense at some of those systemic things play out in terms of how this is interpreted or how it's measured. So I think we'll be looking at that going forward, certainly looking to the literature to support us in how we'd be better able to interpret those measures. When we're looking at, I'm sorry that I missed the first part of, you asked about a particular disease, and I'm not sure if it was BCE that you said, or if you were talking about a specific resistant disease.
No, I just noted that CPE was in the deck that you spoke to, but in the report as a whole, just in terms of antimicrobial, like drug diseases that are increasingly resistant to antimicrobials that are kind of appearing being transmitted in the community.
Thank you.
If there was any data on that, or if there's any thought to including.
Thanks for the clarification. I'm going to refer this to my colleague online, but just by prefacing by saying that the diseases that Ottawa Public Health and all public health units in Ottawa deal with, or Ontario, pardon me, deal with, are part of a mandated list. So depending which disease you're talking about, if it's not on the list, we wouldn't be looking at it. But I'll defer to Dr. Spatz-Friedman online.
Oh, hi. Can you hear me okay? Great. Yeah, so as Cam was saying, we do look at the reportable diseases that have history of antimicrobial resistance, and we're working with Public Health Ontario, the laboratory, to monitor CPE, as well as, of course, TB, shigellosis, gonorrhea, and other agents that have been showing different patterns of antimicrobial resistance. In order that we can follow and keep ahead and alert clinicians as to which antibiotics to be using. Thank you.
We do alerts to physicians if the guidelines for treatment change to address resistance as well. That's an example of how we use our data.
Great.
Thank you.
Thank you, Member Chung. Member Kavanagh, please.
Thank you. I was looking on to forget I'm here in person. I don't have to unmute myself. Thank you very much for that report. It gives a good snapshot of how we're doing in Ottawa. And I can't help but think that this is kind of proves our mandate for Ottawa Public Health and how we should ask for more money because of all the work we have to do. It's pretty clear that what you're presenting is trends and that Ottawa Public Health can deal with. So I'm hoping that that can be the case because in terms of the chronic diseases and the statistics on ages and the fact that there's a lot more people that need information from us. I don't know if you want to comment on that. You're providing the information. It's up to us how to use it, I guess. No comment?
Through the chair, sorry, I was trying to see what where the question landed specifically. A lot of this information will be looking at things that we've talked about in the report, some of the inequities of social determinants particularly. Because whenever we do an intervention, we also need to think about what those implications are. We can actually make those equity issues worse if people of most advantage are more able to take up that intervention. I'm not sure if there was a specific aspect of this you were thinking of.
It's just a suggestion that we need to make good use of this information, I guess. But I'm curious about the senior population, 20%, and growing as people continue to age. One of the things I've been working on in my own community, which has the highest population of seniors, and yes, I'm one of them, but it is the concept of NORCs, naturally occurring retirement communities. I don't know if you've heard of that concept, but that's where providing services as groups so that people can socialize and because, like, for example, condominiums are kind of a good example because who retires there? The average age is over 65, and then you have a large group together. So there's an opportunity to work with them. And there's a pilot project going on in my ward with Carleton University to find better ways to communicate with large groups of seniors, to give them good advice and to help them stay out of long-term care, to keep them in their homes longer. So anyway, just throwing that out.
Great. Thank you, Member Kavanagh. Member Bauer, please.
Thank you, Chair, and thanks very much, Doctor, for the report and for the presentation today. I was struck in particular by the data around mental health and substance use, quite striking and worrisome, no doubt related to the pandemic, but also to other factors such as social media that Dr. Etches referred to in her report today. When I read the report, I may be reading through the lines or misinterpreting it, but it seemed that the population surveys that we put into the field during the pandemic on mental health were, because of the pandemic, we hadn't done them before. I'm just wondering if, given that these trends are worrisome, that if we have the capacity, the resources, the tools to continue tracking these trends as we move forward to keep on top of the evolution.
Thank you. Through the chair. That's a topic that has come up, particularly when you look at stigma associated with mental health. There's been really no precedent data that we've been able to use apart from that population health survey that we initiated. So we're working with the mental health team to start remapping some of these constructs and having a look to see whether an Ottawa Public Health Initiative survey is the best way to get at some of these things. If we look at other conditions, if we think about things like problem gambling is a great example, the most recent data we have from a national survey is 2007. There's been a lot of changes in the gambling landscape with respect to access online, for example, the socialization of sports betting. There are a lot of different things that have changed, and often these national surveys don't necessarily get at the meat of what we're really interested in or aren't necessarily nimble enough for us to find out more. So it's something we take very seriously, and we're looking with the mental health team to see what the best way to enable this is, as well as looking to the future to see what this particular aspect might be. There's different ways we can approach this population health survey rather than necessarily doing it all ourselves.
Thank you very much.
I think I'd like to say I'm very proud of the team. I actually think they're leading the way in terms of how to look at mental health of the community and substance use health in a more comprehensive way, thinking of determinants like housing and other factors right through to are people able to access the treatment they need. There is support. It's in our strategy to continue to work on mental health and to measure inequities. So I think you'll see some other ideas of how we can continue to assess that.
Great, thank you. Member DiGiovanni, please.
Thank you, Chair. And I'd echo Member King in saying this is a mandatory report, but thank you because it's a wealth of information. And I love, one of the things that I love about OPH is we are very data-driven. And so when I look at the strategic plan, I see how we're trying to react to drive some of these indicators. And so that that's a comfort for me as a board member. I guess lots of good information there. And for me, when I read it, there wasn't a big surprise. And I guess you're well into the details. Was there any big surprise for you or any nugget that you thought, oh, this is a change from other years?
Through the chair, it is sort of the same story that we've seen and heard before. I think that what's most marked and what really stands out is one perhaps unanticipated effect of COVID is how starkly it reflected how social determinants makes a difference. Infectious disease typically hasn't been part of that conversation as much as things like chronic disease, where we're looking, or food security and that sort of stuff. But when we look at how it plays out in an infectious disease context, outside of diseases like TB, for example, we really haven't seen it play out, and we haven't been able to collect the data to really show it. So I think it wasn't a surprise, because most aspects of health are affected by social determinants, but to see it so starkly represented here through infection, the mitigation of that disparity through access to vaccination, improved access to vaccination in the community, but still seeing that this burden of health is really unchanged. And there's been lots of conversations about why that happened, in terms of barriers, in terms of people's risk and inability to prevent exposure the way other people might be able to, is part of a bigger context and conversation that I think we need to be talking about, particularly in the context of infectious disease.
That's really interesting, thank you. And it makes me reflect on the spiral or the cascading impacts of infectious disease as well, right? When we don't have paid sick leave, it just further impacts people's ability to work, that further impacts their socioeconomic class. So thanks, I think we should keep our eye on that. It was a really good lesson for us, for sure. Thank you.
Thank you, Vice Chair. I just have one more question. Obviously, you were tasked with looking at Ottawa, but I'm just wondering if if the trends you're seeing here are consistent with trends other municipalities are seeing throughout the province or even the country, or if there was anything that was sort of a differentiator that we're seeing here we're not seeing elsewhere.
Through the chair. For the most part, any comparisons here are made to an Ontario less Ottawa estimate where they are made. Depending what topic you're talking about, there will be very big differences between, say, Toronto, as over 50% of folks identifying from visible minorities, for example, versus a place like Peterborough. So there's a lot of different nuance depending that requires an understanding of the underlying area. But I would say by and large, like the health issues that we're looking at here, so if we take the more recent example of air quality as an example, there are some places that are going to be far more affected by virtue of proximity. There's going to be some areas that are far more affected by the inability of the populace to be able to isolate or discretionally not expose themselves to the hazard. So all these issues are important for everybody. And there's a number of different conversations where that's happening to try to come to consistent measures between different areas. But with all these different measures, there is the capacity to look to say, well, how are we doing to Toronto, which is sort of the big comparator. There are classes of comparison that are set up across health units where we would be looking at what we call peer health units to say these are other cities that have similar demography, similar, say, rural or urban mix, to be able to make those comparisons. Places like Haliburton, Norfolk, HKPR, sorry, Haliburton, Kawartha, and I can never remember the PR, is made up of a multitude of different municipal settings. Ottawa is pretty unique in that regard, that the Ottawa boundaries circumscribe the responsibility of the health unit. There's other ones like Toronto that are massive in terms of the amount of municipal areas that are governed. So it makes a big difference too in terms of how a municipality can actually respond to these health hazards. Are they coming from a unified front? So depending on the topic, the answer is yes, we can make those kinds of comparisons. We don't typically do it. We would more typically compare to the Ontario average, just because these things are so context specific.
And I will add that I think the comparators for us are usually the larger cities, though we have a rural population that's very significant. And at a recent meeting of the Urban Public Health Network, the same concerns for the health of the population were raised. So whether it was a rise of syphilis or the burden of overdoses and too many lives being lost, these are very similar patterns.
Thank you. I'm not seeing any other hands, so thank you very much. Fascinating presentation and information. Thank you. Oh, and can we receive the report? Wonderful. I forgot I have agenda items to do. Thank you. So moving on to item 8.4, Ottawa Public Health Strategic Plan for 2023-2027. We have a presentation, so we'll hear from staff on this, and then we do have a delegation. So we'll do the presentation, then we'll hear from the delegation. Okay. And before we do that, we are going to get Member Carr to move a motion to extend the time because it's likely that we'll go past 7 o'clock. Do you have it?
Be it resolved that the Board of Health approve that the meeting time be extended past 7 p.m. pursuant to subsection 1(8)(c) of the procedural bylaw.
Is that carried? Great, thank you.
Just be close to the mic, please.
Okay, excellent, thanks.
Thank you.
So, bonjour, good evening, Chair Kitts and members of the Board of Health. My name is Cameron Keys, and I am the Director of the Quality, Epidemiology, Strategy, and Technology team at OPH. I'm joined by Jessica Brett and Ikenna Mebagwu, members of the Strategy Planning team. Nous sommes heureux d'être ici aujourd'hui pour présenter notre nouvelle stratégie qui guidera notre travail au cours des 4 prochaines années. This proposed strategy was built upon the strong foundation of our previous strategic plan and continues with an even stronger focus on addressing deep structural and systemic inequities and barriers. It also places significant emphasis on the many valuable lessons, successes, and innovative approaches we have witnessed within OPH and alongside our partners throughout the pandemic. We began the strategic planning process for this new strategy last summer, actively seeking out the diverse perspectives of our community, partners, and employees to find out what they would like to highlight as important areas of focus. Comme le montre la DIPO, notre stratégie d'engagement a été vaste, itérative et inclusive. Through various engagement methods, including surveys, polls, focus groups, and interviews, we completed over 80 meetings with partners and engaged hundreds of our employees to gather their valuable insights. We engaged, adapted, and sought feedback at multiple points during the strategic planning cycle, and this iterative feedback loop allowed us to continuously refine the strategy as we went along. We will continue to utilize the strong engagement approach as we move from strategy development to implementation. Our new strategy's development was heavily influenced by engagement feedback. However, we also relied on other vital sources, such as our recent health status report, to understand the factors that impact our environment and teams and our community's health status. Plusieurs sources ont mis en évidence et renforcé la nécessité pour SPO de prioriser son temps et ses ressources dans certains domaines clés. For example, the pandemic has brought to light the structural and systemic inequities and barriers that existed before COVID-19, and we recognize the urgency and importance of addressing them. With 35% of Ottawa's population identifying as being from a racialized group, there's an even increased need to address these disparities as our city becomes more diverse. We also recognize that the health and well-being of people is directly linked to the places we live and the health of the planet. Climate change poses a considerable threat to human health, while the built environment significantly impacts people's physical activity levels and overall health through factors such as the availability of local services and amenities, as well as the layout of transportation networks. Understanding and addressing these connections is essential. The pandemic intensified many long-standing challenges in areas such as mental health, addictions, and substance use health, and the overdose crisis. Self-harm remains among the leading causes of injury-related hospitalizations among people aged 15 to 44. Additionally, we must combat an overburdened healthcare system. OPH strives to decrease avoidable health issues, keeping people out of hospitals as we support the community to achieve optimal health and well-being. Unfortunately, an estimated 14% of people living in Ottawa do not have access to a regular primary health care provider, which makes our mission all the more critical. It is also important that we need to address diversity, equity, and inclusion within our own organization. Not only is this important for dismantling racism and discrimination, but it also helps to improve professional development opportunities and better serving the community. Racialized staff members have reported experiencing both incidental and systemic racism and discrimination in a recent equity, diversity, and inclusion audit. After gathering and analyzing the information from these various sources and carefully considering all feedback, clear patterns and focus areas emerged that have guided the drafting of our new core purpose and strategic goals. Nous sommes heureux de présenter notre nouvelle stratégie qui définit notre objectif principal et nos buts stratégiques. At the heart of our organization lies our newly defined core purpose. We are guided by a compelling vision and mission that provides a clear direction for achieving our goals. While there are similarities to our previous approach, the inclusion of the concept of places into our vision stands out as an essential difference. By embracing the concept of places, we recognize and acknowledge the critical role that neighborhoods, built environments, and natural surroundings play in shaping the health and well-being of the community. These elements are core to our public health work, and by incorporating them into our vision, we ensure a comprehensive approach to improving health outcomes. Nos 6 engagements stratégiques englobent les valeurs fondamentales et les comportements qui nous engageons à respecter au cours des 4 prochaines années. These commitments include reconciliation, committing to fostering respectful and reciprocal relationships with urban Indigenous peoples, committing to actively identifying and addressing systemic barriers to increase health equity, fostering a healthy, diverse, and inclusive workplace, committing to building meaningful engagement and genuine and lasting relationships with partners and residents, prioritizing and using the best available evidence, which includes community voice and local data, to continuously improve and innovate our work, and finally, committing to optimize our resources to better serve the community and maximize our impact. Our strategic goals represent the next level down in our new strategy, and we will unite our teams around the 5 new goals. Our equity-driven goal to collaborate to eliminate health inequities, systemic racism, discrimination, and oppression is at the forefront of our strategy. To support this goal, we are implementing initiatives such as the collection and utilization of social determinants of health data across OPH programs and the broader health system. We also want to build on the neighborhood approach and other place-based approaches that focus on the specific needs of priority populations. Our second goal, to create conditions to live well and thrive, recognizes the interconnection between health and the built natural and social environments. An example of a key initiative to support this goal is we will continue to actively engage with departments such as city planning, real estate, and economic development to ensure that the city's developments support and enhances public health. The Promote Well-Being and Reduce Harms goal is about reducing stigma, promoting mental health and substance use health, and decreasing harms associated with substance use and addiction. Key initiatives to support this goal include surveillance, training, capacity building, and policy development. Our focus on prevention goal centers around the notion that we will gather, analyze, and share evidence on local health needs and inequities with the healthcare system to strengthen clinical prevention. We will collaborate with healthcare system partners such as Ontario healthcare teams, hospitals, and Ontario Health in engaging data-driven decision-making that better informs our shared efforts. Our fifth goal, enrich our workplaces, is about fostering a diverse, inclusive, equitable, and healthy workforce, and optimize and innovate our processes to better serve the community. Concrete actions to support this goal include implementing our diversity, equity, and inclusion action plan. Our comprehensive strategy highlights both the why and the what we need to do for our journey over the next 4 years. We recognize, however, that the vital challenge lies in the how to achieve these goals. Similar to the previous strategy, to ensure effective execution, the next phase of our work will be to develop and implement an annual strategic action plan with clear objectives, tactics, activities, outcomes, and measures for each goal. This is such a key point that I'll repeat it in French as well. Comme pour la stratégie précédente, nous travaillerons à l'élaboration et la mise en œuvre d'un plan d'action annuel avec des objectifs, des tactiques, des activités, des résultats, les mesures claires pour chaque objectif. Accountability is a crucial component of our strategy. Our Strategic Steering Committee will track its progress on a quarterly basis, and we will also monitor and adapt the strategy in response to emerging public health issues. We are committed to providing regular strategy updates to the board. The creation of our first annual action plan for this new strategy will be presented to the board in the fall, and we will also provide the board with progress reports twice a year, offering insights into our achievements, challenges, and measuring our progress. We recognize that although the road ahead will not be without challenges, these challenges offer opportunities to shift the curve on health equity and prevent chronic disease. Through this 4-year journey, we will have strengthened our collaboration with partners and the community to eliminate barriers, co-created innovative programs and services, and worked with policymakers to shift prevention efforts upstream for a healthier Ottawa. We will have arrived at a more diverse and healthier workforce and have adopted new and innovative ways of working. And by carefully measuring our results, we will be better able to demonstrate our progress to the people we serve and highlight the lasting impact we bring to the community. So on this note, we are hoping for your approval of this strategy, and we will look forward to your guidance, support, and insights along the way. Thank you. Merci. Megwich. Kuyanamik. We are happy to take your questions.
Great, thank you. I believe we have a delegation, so we'll go to the delegation next, and then we'll do questions to staff. So do we have, oh, online, okay. Greg McDougall, you have 5 minutes.
All right, thank you. Can you hear me?
Yes, we can.
Thank you. Yeah, so I would like to comment on this strategy, mainly in terms of COVID, not exclusively. And I'll just start by saying I don't think I'm the only person in Ottawa who's been disappointed by some of the Ottawa public health approach, which I think, to summarize what the problem is, it's been a lot of privatization of health responsibility onto individuals, so that people are responsible for taking care of their own health as opposed to being at public health measures. I think that's the summary of the main disappointment that we've experienced. I think in this strategic plan, something that's missing is that the COVID isn't over. I was reading through it, and it seems to be looking at COVID as in the past, and maybe some in political terms, people are saying the pandemic is over, but I think it's very unsafe to think that COVID is past us. And I think also, not only the however you'd say it, like the immediate threat of COVID for people getting infected, but the long COVID and associated risks of health and of heart, stroke, diabetes, all these complications that are being found in research to come from people having been infected and getting infected again and again. So I don't see any of that reflected as a threat that's recognized in the strategic plan, and I think that's really scary. And I'm not sure how that came to be. Like, what kind of consultation did you do? Did you consult about long COVID? Did you consult with people who have long COVID? I also noted in the State of Health report, there was no mention of long COVID or post-COVID condition as far as I could find. So that concerns me a lot. I'm like, yeah. So I think the question is, do you want to instill confidence in people who have been following the research on this stuff and the kind of the best practices of what we could be doing? And how do you do that? So, and I'm thinking, like, for the forest fire thing, Dr. Etches was on CBC Ottawa Morning and spoke about the difference between the wildfire smoke versus COVID, where she said the wildfire smoke is something that you can't see and can't be stopped by a medical mask, whereas COVID can be. And I don't think that's even science-based. So, I mean, that's why I'm talking about confidence and, like, making sure that these things are important. These things are, like, I don't know, are there checks and balances? Are you taking into account these kind of critiques from people who are concerned, who do have long COVID, who are experiencing the impacts? And just to add, like I said, it's mostly about COVID I want to speak, but I'd also like to speak about the overdose crisis, which the point being that the people who are working on that are calling it a toxic drug supply crisis. And there's no mention of that wording anywhere in the strategic plan. And I think that reflects a lack of listening to the community that's impacted and the community that's trying to change this. So I think, I don't know, like, I hope you deal with that. Thank you.
Thank you very much for your delegation. Do we have any questions from members? Seeing none, thank you very much, Mr. McDougall. Appreciate you being here.
Thank you.
Okay, so we will move to questions to staff, if anyone has questions. Okay, seeing none, well, I want to thank board members for your feedback and input, and of course, a huge thank you to staff for your tremendous effort. I'm certainly very proud of not only the goals, but the values and the vision. So lots to be proud of. Congratulations and thank you. Is this carried? Great, thank you. So we will move to item 8.6, 2023 Operating and Capital Budget, Q1 Board of Health for the City of Ottawa Health Unit Status Report. Member Bauer, I know you had questions. Anyone else can?
Thank you, Chair. I managed to fit it in under your report, so I'm good.
Okay, yep. Wonderful. Thank you. Can we receive the report? Great, thank you. Motion to adopt reports. Member Carr, please.
Be it resolved that the Chair of the Board of Health Verbal Report, the Medical Officer of Health Verbal Report, and the reports titled State of Ottawa's Health 2023, an update, Ottawa's Public Health Strategic Plan for 2023 to 2027, Ottawa Public Health Submission to Health Canada on potential amendments to cannabis regulations, and 2023 Operating and Capital Budget Q1 Board of Health for the City of Ottawa Health Unit Status Report be received and adopted.
Is this carried? Great, thank you. Item 10, motions requiring suspension of the rules of procedure. We haven't received any notices of motion. Does anyone have a notice of motion? Seeing none. Confirmation bylaw. Member Carr.
Be it resolved that confirmation bylaw number 2023-4, a bylaw of the Board of Health for the City of Ottawa Health Unit to confirm the proceedings of the Ottawa Board of Health at its meeting of June 19th, 2023, be read and passed.
Is this carried? Thank you. Do we have any inquiries today? Seeing none, we will move to adjournment. The next meeting is Monday, September 18th, 2023. So I wish everybody a very nice summer at Alpha. This week we had a wonderful presentation about the need to rest and recharge in order to be productive and do the strategic thinking that's required. So I hope everybody takes that advice and has a great summer, and we'll see you in September. Thanks, everyone.